the myths about hospice is that you can't receive certain therapies. We're going to clear up the confusion about the use of speech therapy, physical therapy, and occupational therapy in end-of-life care. You're listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer here with Jerry Fenter.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care. Because we know how busy life can get, Heartbeat is designed to give you helpful information in a bite-sized format.
The Heart of Hospice is partnering with end-of-life educator Barbara Carnes, author of the Little Blue Book, to present a talk at the California Hospice and Palliative Care Association Annual Conference coming up June 6th through the 10th in Orange, California. The conference theme is Back to the Basics at the Bedside and will feature talks on hospice eligibility, documentation, and a 2-day LNEC pre-conference. Visit calhospice.org to register. Be sure to tell them you heard about it on the Heart of Hospice podcast, and we'll see you there. Therapy use in hospice is one of those big misunderstandings. I think sometimes even hospice people don't understand how we're supposed to use therapies.
I'm sure that that's true because I came into hospice not really understanding why certain therapies were not being used. Mm-hmm. It didn't make sense to me until, I understood that hospice is not about making people well.
Right.
It's about giving them comfort.
So when we say therapies, for our conversation here, we're only talking about speech therapy, occupational therapy, and physical therapy. We are not talking about music therapy,
pet therapy,
massage therapy,
aromatherapy.
We are not talking about those. We're going to talk about how these therapies are used in hospice because they are, STOT and PT, are used in hospice, but sparingly.
Right.
Sparingly.
They are not used very often, but they are used in very specific situations.
Yes, with very specific purposes and for limited duration.
So why would we choose to use certain therapies for certain patients?
It's all about enhancing quality of life.
Okay, that makes sense.
A lot of times it's focused on education and the caregiver, things that the caregiver needs to be able to do or needs to know.
Okay, so I have known times when a family would say, well, we want physical therapy.
Right, and it is possible to have physical therapy. So if you have a patient who is on hospice for heart disease, and this patient falls and breaks a hip, has surgery, comes back out, and needs to continue the physical therapy at home and have hospice care again. Absolutely, we can finish out the physical therapy that they would have had, finish out that regimen. But as far as strengthening, that kind of thing, that's more of a home health function. If you're anticipating that the patient will improve, will strengthen, that's not really a hospice goal. So we use it differently. So let's start with speech therapy. Okay. So we use speech therapy in hospice related to swallowing issues.
Okay. Not really for speech necessarily, but it's really about the swallowing issues then.
You can use it for speech on a limited basis as far as necessary communication. If you need to teach a family and a patient to do some necessary communication. But again, I've only seen that maybe a couple of times in my whole time in hospice. It's used mostly to educate caregivers about swallowing issues because we have a lot of patients, stroke patients, Parkinson's patients, Alzheimer's, dementia patients that have issues with their swallowing. They call it dysphagia, and they choke easily. And when a patient chokes, a lot of times they do what we call aspirate, which means they end up breathing in a liquid or a solid, whatever's in the mouth, even their own secretions, their own saliva, and they can develop pneumonia from that. Breathe it into the lungs, and it causes what we call aspiration pneumonia, which is nasty and really causes a lot of suffering.
All right. So having speech therapy can actually limit or lessen the chance of that happening?
Mm-hmm. Because we can teach caregivers how to position a patient, talk to patients about tucking their chin when they swallow, so it helps to minimize the risk of choking and aspirating, things like that. They can also watch how the caregiver feeds the patient or how the patient feeds themselves and give them tips on positioning, body positioning, sitting up at a certain angle, sitting up in a chair so that the swallowing is, I guess, the swallowing ability would be maximized.
Okay. So let's talk about OT, the occupational therapy. Why would we want to use occupational therapy?
So that's more about fine motor, right? Is occupational therapy. So the pincer grasp, things like that. We would use occupational therapy to educate patients and caregivers for managing what we call ADLs, activities of daily living. So it's about the day-to-day functioning. How do they eat? Do they have the right utensils? If a patient can feed himself, but he has, say, a tremor, or he has a visual impairment, or he has an impaired grasp, do they need adaptive equipment? And OT can help with that kind of thing. So say, for instance, a patient that is still trying to feed himself, but has difficulty with utensils, they can provide utensils that have a big cushioned grip.
Okay.
That's just one option for an adapted piece of equipment that would help the patient grip easier, and maybe not a fork, but a spork, or a spoon, things like that. So occupational therapy helps with things like that.
All right. So we've talked a little bit about physical therapy already, but let's go into some of the particular uses for physical therapy.
So that's also for functional issues for activities of daily living like occupational therapy is. So I sort of think of occupational as dealing with fine motor and physical thinking of more the gross motor, the bigger things. So safe transfers, body mechanics, how to safely turn a patient. And again, this is enhancing the quality of life for the patient, but it's really more education for the caregiver. So that's where you get into looking at, you're not going to have a duration of once a week for 5 weeks or 3 times a week for 6 weeks for physical therapy for a hospice patient for something like this. We're going to come in and do 2 or 3 sessions, maybe 3, more than likely just 2. Provide that education. Look to see if they need any other equipment that the hospice could provide to help with activities of daily living, and do they need any education on that equipment? So a Hoyer lift, which is a lift where there's a sling that's placed under the patient. The Hoyer lift has hooks that hook onto either side of the sling. You pump the machine, it lifts the patient up, and it swivels. So you can lift them off the bed or the chair, change the linen, et cetera, and put the patient back repositioned correctly. It can be a little bit of a daunting piece of equipment if you don't know how to use it right. So that's one of the things that a physical therapist could do. Physical therapists could also teach a caregiver safe body mechanics, because there's such a risk of injury when you're repositioning or helping to transfer a patient. So physical therapy could do a lot of that kind of thing.
The Heart of Hospice is partnering with end-of-life educator Barbara Carnes of BK Books to present a talk at the California Hospice and Palliative Care Association Conference coming up June the 6th through the 10th. Barbara is the author of Gone From My Sight, known by hospice professionals as the Little Blue Book. The CHAPCA conference will feature a 2-day pre-conference on June the 6th and 7th featuring the End-of-Life Nursing Education Consortium. ELNEC provides training in palliative care so attendees can teach this essential information to nursing students, practicing nurses, and other healthcare professionals. CHAPCA has invited 3 dynamic ELNEC certified speakers to present the ELNEC curriculum Communication to attendees: Bonnie Morgan, Missy Moore, and Carol Javins. General conference sessions June the 8th through the 10th will feature talks on hospice eligibility for patients with Alzheimer's and dementia, cardiac and pulmonary diagnoses, and documentation for painting the picture of the terminal patient. Register for the CHAPCA conference coming up June the 6th through the 10th by visiting calhospice.org and tell them you heard about it on the Heart of Hospice podcast. So let me ask you this. Should a family just wait for the hospice to decide if they're in need of one of these therapies, or should the family ask and be proactive in seeking the therapies that they might need?
My guidance to any family caregiver, any caregiver that's out there for a hospice patient is to be an advocate. You should always ask, would physical therapy be helpful in this situation? And remember, it's always about advocating for quality of life. So when you think about patients' quality of life, you also have to think about caregiver quality of life, because we're supposed to take care of the whole caregiving unit. So speech therapy, occupational therapy, physical therapy, all of that can improve the quality of life for the patient and enhance the caregiving experience, make it easier, protect the patient's safety. So ask. Absolutely, yes.
Yeah. Okay.
Absolutely.
That's good. So, for instance, what you're talking about is if the patient has one of these therapies, let's say the patient's having difficulty feeding himself. And so what happens is that the caregiver ends up having to feed the patient.
Right.
But if the patient can get enough therapy that they can then begin to feed themselves, that lessens the burden on the caregiver to have to feed the patient.
And we're not talking about fixing the problem. The patient's going to continue to decline, right? The patient's going to continue to worsen and lose abilities. What we're talking about is enhancing quality of life right then, something simple. We're not talking about we're going to do this, every cert period because we feel like the patient will retain instruction. Most patients, so when you think, for instance, an Alzheimer's or dementia patient, Parkinson's patient, and you want to give them physical therapy because they're learning how to walk with a walker. Okay, do that for safety. Teach the caregiver how to transfer the patient, help them get up and down from a bedside commode, that kind of thing, with the understanding that the improvement that they gain at that point is temporary. Right. That's one of the reasons physical therapy, occupational therapy, and speech therapy for Alzheimer's and dementia patients, which is a huge chunk. That's a huge population out of hospice patients, right? That's a very common diagnosis. Those therapies are not effective for our patients except as very temporary stopgap measures only.
So for any family that's considering asking for therapy, you want to keep in mind that if it's even provided, and again, it's up to the hospice to determine whether it's going to be provided, you need to understand that it will be very temporary. It may be only 2 or 3 sessions at the most. That's all that is needed in reality. So just keep that in mind as well.
Right.
We really hope that this particular episode has helped to enlighten and maybe give a little bit of education. It's actually been educational for me, what you've told me about this, Helen. So we hope this really does help our listeners to grasp a little bit more of when therapies are needed and when they might be used to help the patient.
I think a lot of times it's a little bit of a reality check when you get into hospice as a caregiver and a patient to hear the words, no, that's not going to be beneficial. It's hard to hear that. It's a little bit of an addition to your grief burden. It's a way of hearing, this isn't going to get any better, or we don't think this will benefit him.
Right. So if they say no, just understand that they're not trying to take away anything from you, but they also realize that it's not going to be beneficial in the long run.
Now, I will tell you, and we need to add this on, for anybody who is an advocate for a terminally ill patient, a hospice patient, any agency that tells you they do not provide ST, OT, or PT is out of compliance with what they are supposed to be doing by regulation. They are supposed to have access to those therapies if they are needed. So any agency that tells you, we don't do ST, OT, or PT, we don't have those therapies, they are out of compliance. I would suggest that you inquire further into that, talk to the director of nursing for that agency, and consider transferring to another agency.
Okay, very good information to know.
Thanks Thanks for listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer here with Jerry Finter. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening, and please take a minute to leave a rating or a review on Apple Podcasts.
To connect with us, you can send us an email to host@theheartofhospice.com. And you can also find us on all of the social media platforms. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.